Good afternoon, everyone present here. I am Shiraz from IJCP Group. Welcome all the participants on today's webinar. And that is on a very important topic, that is early onset of gestational diabetes, screening and management decisions. As we know that this is an important topic, so we need someone who is expert. So I would like to welcome today's speaker with great honor, none other than Dr. Parag Beniwale sir. And let me share some of the achievement of sir. Sir is senior consultant Opsi and Gynae at Pune, and he is PG teacher and unit head Kamala Nehru Hospital, chairman of Indian College of Opsi and Gynae, and president of Menopause Society Pune 2018-2022, president of Pune Opsi Gynae Society 2022-2023, and peer reviewer Journal of Opsi and Gynae of India, Journal of Midlife Health, chairman Young Talent Promotion Committee Foxy 2008-2010, and edited three books, co-editor of three books, contributed many articles to books and journals, and delivered orations, guest lectures in over 170 Foxy societies, recipient of Best Paper Prize in AICOG and AMOGS. So without any further delay, I would like to welcome sir and hand over this session to sir. Sir, the stage is yours. You can proceed from here.
Thank you, Faraz. Good afternoon. I bring greetings from Pune, and it's indeed a pleasure to have a dialogue with everyone on a very pertinent subject, uh, that is gestational diabetes mellitus. And today I'll be focusing mainly on early onset gestational diabetes. Now, we have to first understand magnitude of the problem. Hyperglycemia, in fact, is one of the most common medical conditions that women encounter during pregnancy. It is estimated that 1 in 6 live births occur to women from in some form of hyperglycemia, and 84% of which is because of GDM. Why we are concerned about hyperglycemia? Because it is one of the important causes of maternal mortality. There is increased maternal morbidity, and also there is a higher incidence of perinatal and neonatal morbidity. What is most important probably is the long term late sequelae for both mother and the child. The challenge of HIP is huge. World over, it is estimated that there are 127 million birth takes place. More than 65 million deliveries are conducted in countries like India, China, Pakistan, etc. It is also estimated that 21 million pregnancies are complicated by hyperglycemia, but unfortunately, only 3 to 4 million of them is detected and treated in time, and hardly anyone receives postpartum follow up and lifestyle advice. And this leads to so many issues in the postpartum or later life of that particular woman. So, hyperglycemia in pregnancy, we can divide it in pregnancy in a pre existing diabetic woman, or diabetes diagnosed in pregnancy for the first time, and that is gestational diabetes. What is exactly early gestational diabetes? Now, typically, we say that whenever there is hyperglycemia after 24 weeks, we traditionally label it as gestational diabetes mellitus. But whenever we diagnose diabetes, gestational diabetes, before 24 weeks, and then when it fulfills the criteria, we say that it is early gestational diabetes. Of course, we have to rule out over diabetes in these women. How common is this condition? Worldwide, there are so many women who are suffering from hyperglycemia in general, but in our country, in Southeast Asia, 15% is what is postulated. In our country, 1/3 of pregnant women do experience hyperglycemia in pregnancy, 33% in the first trimester, and these basically contribute to the early gestational diabetes. Why we are so much concerned about gestational diabetes in general and early gestational diabetes in particular? That's because there could be spontaneous miscarriage. Women may face challenges like preeclampsia, gestational hypertension, recurrent urinary tract infections, macrosomias, or hydramnios during pregnancy. The childbirth is not easy. There could be preterm birth, instrumental delivery, traumatic vaginal birth, more chances of C-section, more possibility of postpartum infections, postpartum hemorrhage, in general, increased maternal mortality and morbidity. And this misery continues even in the puerperal phase because women are more prone for infections and lactation failure, leave alone the long-term postpartum issues like weight retention that is leading to overweight or obesity, gestational diabetes mellitus in subsequent pregnancies, diabetes mellitus, and cardiovascular diseases. The offspring is not spared either. So the neonates are troubled by the hyperglycemia in utero. We get to see more of Conge anomalies, difficult deliveries in the form of shoulder dystocia. These babies are uh, do develop RDS or transient tachypnea of newborn at birth, more chances of neonatal death and even stillbirths. This problem also can present as hypoglycemia, hyperbilirubinemia, hypocalcemia after the baby is born, and this acts as a precursor for fetal origin of adult disease. So it is really very, very important to offer good preconception care, and this includes not only folic acid and B12, but lifestyle modification is extremely important because preconceptionally we should screen these women for obesity, diabetes, and other conditions like anemia, hypertension, etc. Control it and then ask woman to become pregnant. So pre-pregnancy counseling and optimization is very, very important. So we must look for complications of diabetes if she's found to be diabetic earlier. And if she's planning pregnancy, we may have to switch to insulin and then do a proper screening for retinopathy, coronary heart disease, etc. Now, the big question is how to diagnose gestational diabetes mellitus because there are so many organizations who put forth their views and various screening tests. So there's always a confusion as to which method to adopt to make a diagnosis of this particular condition. And for us Indians, the government of India, the DIPSI, that is Diabetes in Pregnancy Study Group of India, and the Federation of OBGY Societies of India do recommend universal screening for all Indians. And the first testing has to be at the first booking visit. So it is prudent that women visit the obstetricians in the first trimester because this is the time we can initiate screening and this is the time for us to diagnose early gestational diabetes mellitus. Traditionally, the second testing would be between 24 to 28 weeks, and DIPSI and FOXY do recommend a third testing at 32 to 34 weeks if the first two screening tests are negative. So, how do we do this particular test? So, for us Indians, it is worthwhile considering the DIPSI test because it is researched on Indian population and it is meant for us because we are high risk of developing hyperglycemia in pregnancy at any stage, being the diabetic capital of the world. How do we do this test? So it is a single step test, so no repeat blood samples are required. It is done with 75 grams oral glucose and a single reading of blood sugar is done 2 hours after ingestion of glucose. So 75 gram of glucose is dissolved in about 300 ml of water, and the woman consumes this in 5 to 10 minutes. It really doesn't matter if she's fasting or non-fasting. She can do the test at any time during the day. A plasma standardized glucometer should be used to evaluate blood sugar 2 hours after the glucose load. Now, if the woman has vomiting within 30 minutes of glucose intake, the test has to be repeated at a later date. But if the vomiting occurs after 30 minutes, the test continues. How do we interpret the results? Now, what we expect is when the plasma glucose level is less than 120, we say that it is normal. If it is between 120 and 139, we call it gestational glucose intolerance. If it is more than 140 but less than 199, so it is gestational diabetes mellitus. And when we do it in the first trimester, we would call it early gestational diabetes. However, if the value is more than 200, then possibly we are dealing with a woman who has over diabetes mellitus. It was somehow missed, and now we are diagnosing it for the first time when she's pregnant. So, in such women, we have to look for hypertension, look for nephropathy. Fundal examination is important to rule out retinopathy. What is the role of HbA1c? Now, HbA1c, all of us know that will tell us the average blood glucose level in the past 2 or 3 months. So, if the normally we expect the value to be less than 5.7, and when it is less than 5.7, we are really assured about that the woman is not suffering from type 2 diabetes mellitus or pre-diabetes. If the value is more than 6.5 or higher, we would certainly label her to be diabetic. But what is very important is about the values. Now, when the value is less than 6.5, it means that the patient is not diabetic, or if she has glucose intolerance, there is a very low risk of congenitals. If the HbA1c is between 7 to 8.5, then the risk of congenitals is 5%, and when the value is more than 10, the risk could be as high as 22%. And this is something which is really important for us to know, because whenever we have a woman who comes to us with gestational diabetes mellitus early in pregnancy, this is the important counseling point that we must all remember. So it is really important that we monitor these women well. So we ask them to come back for regular antenatal visits as per schedule, or more if needed. Weight gain is something which has to be controlled, so good counseling is needed on that front. We of course keep on monitoring her blood pressure. Fundal height is very, very important, and abdominal girth, that will give us a clue whether the ongoing pregnancy is getting into macrosomia or not. So we ask women to take monitor daily fetal movements count, and of course antenatal restricting weight gain in the antenatal period is very, very important. And how much weight gain is permissible? If the woman is obese, we should encourage her to put on about 5 to 9 kgs. If she's overweight, about 7 to 11.5 kgs. So we must uh, ask her to see a nutritionist. We must ask her to start doing regular exercises in order to maintain weight gain under control. What is important in management of early onset gestational diabetes is medical nutrition therapy. It is started with the aim to achieve normoglycemia, to prevent ketosis. It also aims at providing adequate nutrition and providing adequate gestational weight gain based on maternal body mass index. And of course, it should and it would contribute well to the fetal well-being. This is a chart which is really important, because these are the important aspects of medical nutrition therapy. So we must calculate a requirement of carbohydrates, especially in women who have this GDM. So low GI diet is important. Fibers should be adequate. Protein, energy, fat, all these to be should be measured and asked. We should ask the woman to consume it. Of course, it is important that we give supplements of vitamin D, folic acid, and B12, and even iodine in order to maintain a good nutrition in these women. So it is important that we do a glycemic surveillance in these women. So what we normally recommend is a fasting and two post-meal blood sugar 2 weeks after the woman follows medical nutrition therapy. So let's take a situation where a woman who's at around 10 weeks is diagnosed as gestational diabetes mellitus based on the DIPSI test. So we ask her to do a good medical nutrition therapy, ask her to come back after 2 weeks, and we ask her to do a fasting and post meal sugars. Now, she can do these tests on her own on a glucometer, or she can get these tests done in the lab. So we have to ask her to keep a good record of these sugar levels so that we know how the woman is doing during the course of pregnancy. And later, as the pregnancy grows, it is important that we keep on doing surveillance of the fetus with the help of ultrasound and color Doppler as appropriate, and non stress test, which is generally offered every week. If the woman is on insulin after being detected as early gestational diabetes, we should start doing NSTs at 32 weeks. But if she has gestational diabetes and we are offering her uh, something like metformin, she can continue the surveillance from 34 or 36 weeks. So if the GDM patient has a good glucose control, we counsel her. We have to be reassuring her that there are no other pregnancy complication. And generally, if her glucose control is good, we don't expect her to develop macrosomia, preeclampsia, or growth restriction. So typically, for these women, we should suggest NST and ultrasound, of course, for AFI and biophysical profile after 36 weeks. If the glucose control is suboptimum, we should counsel her. Glucose monitoring is continued, the nutrition therapy continues, and then we introduce the insulin or oral hypoglycemic drugs if needed. Typically, as per the Government of India guidelines, women with early onset GDM which are not controlled only by medical nutrition therapy, the ideal treatment would be to start insulin. And in general, whenever we are asking the woman to start insulin, we would have a physician on board who will help us controlling her blood glucose levels. And if this pregnancy is uncomplicated with a good glucose control, we can continue monitoring her fetal weight, especially between 36 and 39 weeks, and then take a delivery decision accordingly. But if the pregnancy is has or the glucose control is suboptimum, or if she's on insulin or oral hypoglycemic agents, we may have to call her twice weekly if needed. And of course, free ultrasound should be done at 30 to 36 weeks and more so if needed. What is the role of ultrasound? So we would subject all women who have early gestational diabetes to an NT scan, where we would monitor the growth. We would look at the presence of nasal bone and measure NT. Uterine artery Doppler is also done because this screening will tell us whether she is more prone for preeclampsia, and of course, if she has high NT or abnormal TR and DV, these are the surrogate markers for fetal cardiac anomaly. Now, ACOG suggests that ultrasound fetal surveillance should be continued in women who require pharmacological interventions, and here we would do a frequent monitoring, maybe every month or every 6 weeks, depending on the clinical situation, and monitor the fetal weight in general, and fetal liver length also is an important aspect, or it would give us a good clue about the fetal growth. What is most important in women who have early gestational diabetes or who are diabetic and become pregnant is detecting congenital anomalies. So, pre-gestational diabetes is associated with increased risk of malformations. It was found out that diabetic pregnancies result into 6 to 10% of conj anomalies. So, ultrasonography as early as 11 to 14 weeks can identify some conj malformations. The detection of other malformations may need confirmation later at 20 to 22 weeks, and of course, in a diabetic woman or in a woman who has early onset GDM, it is prudent that she undergoes fetal echocardiography. These are the common anomalies which may be seen because of early onset uh, gestational diabetes mellitus or with uh, type 2 diabetes mellitus. And it could be facial anomalies like cleft lip, cleft palate. There could be renal anomalies, gastrointestinal anomalies, very importantly, cardiovascular anomalies, because they are far more common than any other abnormalities. And of course, we have to keep a watch on neurological abnormalities like neural tube defect and hydrocephalus, because these babies do require critical monitoring. We also should be monitoring the placental changes in women who have early gestational diabetes mellitus, and we know that the placental changes in pregnancy can predict possible complications. So, placental vascular indices calculated using Doppler ultrasound in early pregnancy, that is in the first trimester, can actually give us an insight into a possibility of developing gestational diabetes mellitus. What is the role of 3D power Doppler? Placental vascular indices, in addition to placental volume and uterine artery PI obtained in the first and second trimester, uh, would be of great help. The changes in the VI and VFI as early as first and second trimester occurs before clinical diagnosis. How do we predict the outcomes? Now, if there is macrosomia, uh, we have to be really vigilant because these are the babies who are likely to have issues during the birth process, and these are the babies who would land up in shoulder dystocia. And of course, the chances of the woman requiring C-section are far more when the baby is macrosomic. So these are the recommended scans we should be doing. Let's not forget to do a, a double marker test or a quad test or a quadruple screening, and if required, NIPS. How do we monitor these pregnancies? So in the first trimester, apart from clinical examination, dating scan, NT scan is a must. In the second trimester, the clinical examination continues. We would do an anomaly scan at around 19-20 weeks, fetal echocardiography at 22 weeks, and the third trimester, apart from the clinical management of patient, we would do growth scans at 28, 32, and 36 weeks if needed. Now, how different is early GDM and versus late GDM? And this was one very interesting study from Sao Paulo, which has explained it well. They have compared women who developed early gestational diabetes to those who developed late gestational diabetes. So, what they found out was uh, there were differences in the birth and newborn characteristics. If you look at the slide carefully, uh, the chances of low Apgar were more in women who had early gestational diabetes mellitus. Uh, if you look at the fetal weight, the early gestational diabetes mellitus were likely to be having less weight. And in the postpartum phase as well, It is important that we monitor these women, and we should not forget that in women who have early gestational diabetes are more prone, or there is an increased risk for gestational diabetes mellitus than women in late gestational diabetes. What is most important is this particular study by Dr. Sheshaya, and in 2023, he has mooted a concept of primordial prevention, and that's a futuristic approach to intervene in women who have gestational diabetes and its sequelae. So it is really, really worthwhile doing a first screening test very early in the pregnancy, maybe even at around 8 weeks, and we can actually program the developing fetus. So pre-pregnancy planning is ideal for better fetal outcome. It is necessary to optimize metabolic control early in pregnancy. We should predict uh, development of gestational diabetes and its consequences at around 10 weeks when a postprandial blood sugar is more than 110. We must try and take preventive actions at 8th week of pregnancy, and ask these women to follow medical nutrition therapy throughout, and in some of them medical nutrition therapy plus metformin can be continued till confinement. So to conclude, the prevalence of gestational diabetes has been increasing over in the past decade. Screening of gestational diabetes is usually conducted in the first trimester, then at around 24 weeks of gestation, and it is necessary to manage the condition to avoid further maternal and fetal complication. So, early diagnosis of GDM is a must. Clinical monitoring, along with judicious use of fetal monitoring, is important. Ultrasound can potentially detect developmental abnormalities and placental changes early in pregnancy, allowing the physicians to predict possibility of developing gestational diabetes ahead of time, and also allows better management and early course of action to avoid any complications. And all obstetricians should train themselves to identify gestational diabetes mellitus properly. So thank you very much. And once again, I thank Team IJCP for having me here and asking me to talk about a very, very important condition, that is early management of gestational diabetes mellitus. Thank you.
Thank you so much, sir, for taking out your important time and sharing your knowledge on this topic. I definitely think this session knowledge is going to help all the participants on their practice too. Sir, we have received some questions, sir. With all your permission, shall we take these
Sure,
questions
sure.
one by one?
Please go ahead.
First question is from Dr. Snehali, and she's asking, do you prefer the DI-PSI one-step test or two-step OGTT methods in early pregnancy, sir? What's your
Tipsy
point of
one
view on
step.
that?
For last 17 years, we are doing only DIPSI testing. We do it the first testing because I'm into private sector. We do the first test at around 8 weeks. If that test is normal, we repeat test at 24 to 28 weeks. And if the second test is also normal, we do a third testing between 32 to 34 weeks. And this is what the DIPSI and FOXY also recommend.
Thank you so much, sir, for sharing your insight on that question. Moving forward, we have second question, sir. How do you distinguish between undiagnosed pre-gestational diabetes and true early onset of GDM, sir?
Right, it is difficult to diagnose because, see, when you the only thing probably is when you do a DIPSI test early in pregnancy. If the value is more than 200, you know that you are dealing with a woman who has over diabetes, but it was somehow missed during this course of time. And when the value is between 140 and 199, we call it early gestational diabetes mellitus.
Thank you so much, sir, for answering this question. One last question I will take, sir. Are HB1AC or fasting plasma glucose reliable early indicators of GDM? What's your point of view on that?
Okay. Now, HbA1c will not have, implication as far as diagnosis of GDM is concerned. It is very important to have HbA1c values, especially if the woman is diabetic, because if, as I mentioned in one of the slides, if the HbA1c value is more than 10, then there is almost 22% chance that the baby may have some kind of Cron's anomalies. So it is worthwhile doing an HbA1c, but there is no need of repeating HbA1c every month. There are some people who do it, but it is not required at all. I would not simply rely only on fasting levels, but as this study by Dr. Sheshaya, a postprandial level of around 110 or more can be considered, especially at around 10 weeks, can be considered, uh, or we should be very suspicious about this particular value, because these are the women who are likely to develop gestational diabetes mellitus at a later date. But for me, it is only DIPSI, and DIPSI for diagnosis of gestational diabetes mellitus.
Thank you so much, sir, for sharing your insight on that question, sir. I can't see any further question from the participant. I hope, sir, you have done justice to this topic and able to solve all the questions related to this topic. Sir, as there is no more questions, sir, with all your permission, shall we conclude this session for today?
Sure, sure. Thank you very much. Thank you, Faraz, and thank you, Team IGCP, for having me in this webinar today.
Yes, sir. Sir, we would like to see you in future also with different topics, sir. It was great honor to host you, sir. Thank you so much
Sure,
for
my
giving your
pleasure.
valuable
Thank
time.
you. Yeah, bye
Welcome,
bye.
sir.